Okay, continuing on our discussion about aortic dissection, I'll now talk about management of dissection. It's very important that we always keep in mind that the best way to manage these cases is to understand the clinical manifestations and presentations. That goes for any of these diseases or any of these syndromes that we see. So one of the things that we have to be aware of is something called acute aortic syndrome. Acute aortic syndrome is a group of conditions that affect the aorta, such as intramural hematomas, aortic dissection, uh, an aortic ulcer, thoracic aortic ruptures. These cannot be distinguished clinically. They can only be really differentiated upon surgery. So that's why we have to look at the subtleties of these things to really be able to make a good diagnosis. No matter what, regardless of the Stanford classification, we always want our patients to either A or B. We should refer them to cardiothoracic surgery in case of regardless of the Stanford classification, because even though if a Stanford class B, which or type B, which typically is not a medical emergency, but those that have a higher risk where that type B can become life-threatening, we want to consult cardiothoracic surgery. So when we look at the management of hemodynamically unstable patients, these patients can present with shock and cardiac arrest, right? Severe hypotension, severe hypertension, acute, different, as I mentioned, acute coronary syndromes, cardiac tamponade, and acute aortic regurgitation. You may need to resuscitate them with ACLS. And also one thing we should do is look at how we can diagnose our patients do via investigation. So that can include an ECG, that can include a chest x-ray done bedside. That can be a bedside echocardiogram, so transesophageal, transthoracic echocardiograms, and a point of care ultrasounds. What we can also do is that if a patient is presenting to us that has life-threatening conditions, we want to give them hemodynamic support. We want to manage, especially cardiac tamponade, which can occur if there's a rupture of the adventitia. So we want to be considering all those factors. The one thing that you should remember with diagnosis of aortic dissection is the gold standard of diagnosis is using a CTA, which is a computed tomography angiography. And that is only really useful when the patient is stable. If they're not stable, we can't really do that. So I've added this slide for completeness sake, but one thing that we can do is something called a pretest probability. So a lot of these conditions may mimic one another. So dissection can mimic an MI, a stroke. So by looking at these like little red flag signs, so such as truncal or neck pain, end or neck pain, neurological features, syncope, acute limb ischemia, those can all help us kind of narrow in on the diagnosis of dissection. And so there's something called the Aortic Dissection Detection Risk Score, or the ADRS. And it's a clinical tool that's used in order to, that's measured from a scale of 0 to 3. And if those patients present with such complications, then the higher their number, like 2 or 3, they're in more severe category, and we probably want to give them definitive imaging, versus those who are 0 or 1. We can use like ECG or other studies for them. So the diagnosis is pretty important. ECG should be conducted for every patient. And I will discuss in a few slides what we look for in the ECG. Order lab studies. This is where I think it's pretty important to distinguish this idea of, or make sure to clarify this idea of a D-dimer. D-dimer may or may not be elevated. Some patients' D-dimer levels will be elevated if they have dissection. Some will not. There have been some studies to suggest that if they are not elevated, that they do not have dissection. But again, we got to be cautious and not use that as a definitive factor. Okay, we can do a chest X-ray, transthoracic echocardiogram, and the point of care ultrasounds. Those will all help us as modalities for screening. However, definitive imaging is that CTA, as I mentioned, that computed tomography angiography. We'll just give them IV contrast, radio contrast agent, and diagnose using a CT, and basically visualize the vessels and visualize the anatomy of these vessels. Now, definitive imaging, because of that, we can identify a false lumen via like a CTA. So this table I've included as a reference for you. It's a pros and cons, but just main takeaway is that a CTA or the CT angiography is a gold standard for imaging with stable, hemodynamically stable patients for dissection. ECG, this is where it kind of is variable. ECG can be normal. ECG can show signs of left ventricular hypertrophy. You can see ST segment depression and T wave changes, ST segment elevation. So there is a case that I will discuss that is just specifically looking at a 12-lead ECG, and you'll see basically AVR showed ST segment elevation. A chest X-ray, what we'll see is a widened mediastinum. You can see this image to your right, a widened mediastinum that's more than 8 centimeters at the level of the aortic knob. And the aortic knob is right at that top portion, just for those that are watching the video. That's this portion here. This is the aortic knob. You can see it's quite widened. And we also have here altered mediastinal contour, calcium sign. So near the knob, you'll see like this streak. And this streak can be very indicative of dissection. There are other presentations that I've listed in those bullet points, such as pleural cap, pleural effusion, or tracheal shifts. But a lot of times a normal chest X-ray may appear. A patient presents to you with a normal chest X-ray. And let's say we know that they have dissection. But their chest X-ray is normal. So that's why you don't want to be, this is not a definitive, it cannot be used as a definitive diagnosis, because some people present with normal chest X-rays. As I mentioned, D-dimer, don't rely on just D-dimer itself, but also look at the signs of end organ damage. So if there's elevated levels of troponin is released by these cardiomyocytes when they are damaged. So that can be one biomarker. BMP, doing a basic metabolic panel, testing for sodium, potassium, like chloride, bicarbonate, nitrogen, creatinine, glucose. Maybe test for calcium as well. And then lactate levels, which is the end product of anaerobic glycolysis. And additional findings is going to help you further in that chest X-ray. So going back here, those additional findings may help you further establish a valid diagnosis. Now, as the gold standard is a CT angiography of either the chest, of the abdomen, or the pelvis. And you can visualize beautifully that intimal flap dissection and the double lumen, and you'll see the contrast leak into the false lumen, so you can really well differentiate a true and false lumen and see the dissection. A lot of times standard CT, this is where standard CT kind of fails us. So the standard CT on the image to your left here, as you can see, this image right here shows us is a standard CT. And you'll see a faint streak here. Now, a patient could present with such a streak, and then you would say, oh, this patient has Stanford type A aortic dissection. But that might just be an artifact of imaging, because recall the heart is beating. right? And as the heart beats, you're imaging something that's moving, it's going to create artifacts. So what clinicians have smartly um, this, done to kind of circumnavigate this issue is they do either retrospective or prospective ECG tracing. And the heart, when it's in diastole, that's when that's when there will be imaging, CT imaging. So the image to your right here, so this image, this patient does have dissection. I should make that clear. This was done with standard CT, but we cannot be definitively sure because it could be an artifact. But figure B was an ECG gated CT, and from this we see the true and false lumens. You see a dissection. And you can see the pulmonary trunk there. So this is involving the ascending aorta. This is Stanford type A. This is life-threatening. Okay, so this is an ECG-gated CT scan of a patient who has Stanford type A. So I'll play this out here for you, but I'll skip to the more pressing part here. And you can see beautifully the dissection here, right? You can see the true and false lumen, and this is involving only the ascending aorta. The descending aorta is not involved. And so therefore, this is a Stanford type A. There was valvular repair done. That's why you'll see some of those metal highlights there. But the next one I have is of Stanford type B. Now, Stanford type B here, you can see this is involving the descending aorta in this case. And you can see that true and false lumen in that in here. And you see it keeps going down, 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 that descending thoracic aorta. There's a few things I would like to know about this patient specifically, why this patient actually presents with a surgical emergency. So I mentioned Stanford B can typically be medically managed. They don't need surgical intervention. This patient would probably need surgical intervention for a couple of reasons. One, the lumen of the left, so that false lumen gives rise to the left renal artery and the inferior mesenteric artery. So that got displaced and got torn off from the true lumen. So blood is not properly perfusing those vital organs. So in this patient's case, their left kidney was kind of showed signs of ischemia, and also malocclusion. So this can cause ischemia and damage to other like abdominal organs. And yeah. Okay, so a TEE, a transesophageal echocardiogram. So you can see on this patient here, they had to do this because they had renal insufficiency. But specifically, if a patient does have end organ damage, or if they have a contrast allergy, we cannot do a CTA. So this is where we need to do like this or if they're hemodynamically unstable, we'll probably need to do a TEE on the bedside. You can see very clearly there's the false and true lumen. You'll see this lumen here. And you'll see the dissection flap. And you may even see thrombosis. MRI, these are typically can be used more so for our younger patients. They take longer to acquire, but it's basically gives you, with contrast media, gives you kind of like frames that you can like play back. And from this, from left to right, the left image shows us the red and blue arrow. The red arrow is the true lumen, and the false lumen is the blue arrow. And so from left to right, you'll see, when you do the imaging, you can see the movement of the blood and the true and false lumen. Again, MRI is advised instead of CT to avoid ionizing radiation. So this is more done for younger patients. Okay, so now let's talk about treatments. So treatment, type A, no matter what, needs surgery. B, depends. That patient case with the CT I just showed you, that patient, because they showed ischemia to vital organs, that's going to need surgical intervention. But other cases might not need. Blood pressure control is essential for patients regardless, so lowering that blood pressure. and also making sure their blood pressure doesn't go too low, right? So having that fine balance, supportive care. And this is a subtle point. We don't want to give thrombolytic agents to these patients who have dissection because they could be at risk for an MI or stroke. Surgical therapy should be done for all Stanford A dissections. B, again, it depends if they have end organ damage, hypotension, persistent severe chest pain, hypertension, expanding aneurysm, propagation of the dissection, expanding hematoma, rupture. All those I've listed here, those are cases which make sense that the patient should undergo surgical treatment. And they'll just go in and they'll place an endovascular stent graft. There is a distinction though. I'm not going to be explaining the surgical techniques, but just for your information, anything that involves the ascending aorta, aortic arch, they typically do not use the endovascular stent graft. Medical therapy. For these hypotensive patients, we need to maintain a mean arterial blood pressure of 70 millimeters mercury or euvolemia. That could be either through IV fluids. That could be through vasopressor support, norepinephrine. We do not want to give these patients ionotropes. Ionotropes will cause the heart's, the striatal stress to increase, and that can cause, and especially in the left ventricle, and that can cause, because of the increased force from the left ventricle, the aortic wall to rupture even worse. We want to be careful because identify and treat if possible comorbidities, for example, from that like cardiac tamponade. So we may need to do pericardial fluid drainage. Expedite operative management, avoid ionotropes, right? Hypertensive patients, on the other hand, we can control that with hypertensive medications. So, and we want to create the heart rate in a nice target range of less than 60 beats per minute, and systolic blood pressure between 100 and 120. So we give them an IV beta blocker and then a vasodilator. We do that in that order. It's very important. Beta blocker, IV beta blocker, followed by the vasopressor or vasodilator, excuse me, vasodilator. We do that after the beta blocker because we don't want to have reflexive tachycardia. Sometimes some patients cannot tolerate beta blockers where it may be contraindicated. So we'll give them a calcium channel blocker. It's important for supportive care. So supportive care is important because we want to help the pain and anxiety. So we want to help, talk with the patient, bring, de-stress them. We may need to give them morphine for pain management, anticoagulants. If they are on anticoagulants and they go into surgery, we want to take them off of them. So we need to consult hematology. Prevention. So prevention is very straightforward. Blood pressure control, hypertension, as I mentioned, in 70% of cases can cause that, right? So can cause dissection. So we want to control blood pressure. Cessation of smoking is very important. And then age-appropriate AA screening. So this is a little bit of excessive information, but I just want to keep you informed. Men age 65 to 75 with a history of smoking should undergo this testing, where basically they'll just do an abdominal ultrasound and just see if they have this. Women typically get it as well, but it's more 65 to 75 with a history of smoking. They can get it, but again, men are more at risk than women. If women who have never smoked or don't have family history, there's no need for them to get that screening.